All right. So thank you for joining us for today's webinar. Data can be your friend. Hopefully by the end of this webinar, you will have a sense of how you can use data in your recovery-oriented practice. First, I have to put up this disclosure slide that's required by the CME accrediting body to show you that all of the faculty and planners associated with this activity have no financial arrangements or affiliations with commercial entities that would influence this presentation. The learning objectives for today are first to describe how to set specific and measurable goals, then to understand the importance of reliability in data collection. Then we'll talk about how to use the Plan, Do, Study, Act model of quality improvement, and finally how an implementation plan can guide quality improvement efforts. So why care about data? I mean, isn't everybody on their own journey of recovery, and it's personal and unique for each person? How can you even measure that? And isn't it really data about managers or executives needing numbers for some report or for billing? And besides, it's boring. So we'll just take a look at these one at a time. You're right, recovery is unique and personal, and everybody's journey is their own. Even so, SAMHSA, the Substance Abuse Mental Health Services Association, federal government, put out some papers around recovery and noted that it tends to happen in 4 domains: health, home, purpose, and community. And they further specify that recovery is built on access to evidence-based clinical treatment and recovery support services for all populations. So you're implementing evidence-based tobacco use treatment, as you learned from Jill and from Rusty and Noah, really help somebody along in their personal recovery journey. And as you can imagine, it would have a tremendous impact on the health domain of recovery. As you're probably remembering from the training, it's the #1 cause of death for people with behavioral health conditions. And even if you think about the health issues that come up around smoking along the way, even before somebody dies in early death, they'll have more cardiovascular issues, some trouble breathing, and so on, that also impact people's wellness and recovery. So yes, in terms of data being for management and billing, data can be helpful to management and billing, but it can also be helpful for you to understand whether what you are doing is making a difference, and consumers can use data themselves to follow their own improvements. I'm sure we can all think of personal experiences with this, whether we have a Fitbit or we've tracked calories or weight and looked at that our own selves through time, that could be very helpful for us. Excuse me. I apologize, I have a little bit of a cold. So now let's look at this idea that data is boring. All right, okay, maybe it's not a party, but it doesn't have to be boring. If it's done right, it can be a meaningful part of a recovery-oriented practice. So how do you get started? The first thing you want to do is put together a work group. And hopefully many of you are already part of a work group as part of this tobacco initiative, but if not, there's still time. It's helpful to include consumers, administrators, supervisors, and clinical staff. And you want to ask, what are you going to improve and by how much? And you want to be really specific about this. How much and by when? So you don't want to just say, we want to screen more people for tobacco use, or we want to see more people with a quit attempt. You want to get specific. You want to say at least 25% of consumers with tobacco use disorders will have a quit attempt, or we'll screen 90% of consumers for tobacco by February 1st, 2019. Thank you for joining, Megan, and for letting me know that there was trouble with the link, so I I have sent it out to the group of people, so hopefully we'll have some more folks join us. Going to apologize ahead of time. I'm fighting a little bit of laryngitis, so I'm doing the best I can. So we just started to lay the groundwork, actually, about what kind of data you would collect, and we talked about how specific you want to get about how much you want to change and by when. So instead of saying things like, we just want to increase the number of medical records that have tobacco use disorder documented, you would actually say something like, we want tobacco use disorder documented in at least 90% of the relevant medical records by, and to have a particular date. So what are some things that people look at when they are thinking about making changes? One area people will tend to look at are procedures and policies. So do we have procedures and policies in place that can promote better outcomes? So for example, how do we that can promote better outcomes? So for example, how do we orient new staff? Do we train them in how to treat tobacco use? Do we include tobacco screening and diagnosis in medical records or treatment plans? Another area where people might look is whether practitioners are doing anything differently. So are they running groups using manuals that specifically target tobacco use, such as the Learning About Healthy Living manual or even Wellness Self-Management Plus? Are they actually screening or talking with every participant they see about their tobacco use? And finally, people will look towards consumer outcomes. Are they improving their health? Are they attending groups to address tobacco use? Are they making quit attempts? Are they reducing the number of cigarettes that they're using? So once you've figured out what your goal is and what you might want to track, then you want to choose what measure you're going to use. And when I think about collecting data and measures for quality improvement, I think in three areas. Is it doable, is it reliable, and is it related? So in terms of something being doable, you want to make sure that you are choosing something that is likely going to happen in your setting. People are very busy, and it's hard to think about adding just one more thing to do in anybody's daily schedule. So you might come up with this wonderful, huge spreadsheet that tracks, 500 different beautiful variables that would be very informative, but if it takes somebody an hour in their day to do it, it's never going to be done. It won't be doable. So you have to think really carefully about what your goal is and focus very specifically on that. So if you want to increase the number of people who have a quit attempt, where can you capture that information easily? So for example, if you are already collecting data, if you have a medical record that documents quit attempts, or you have a survey that you're using, quarterly with consumers that documents this, just think about where you might already have existing data that you can use for this purpose, because that will be your most doable measure. If you do have to collect additional data, just make sure it's as simple as possible. So, that could mean both in the process, for example, putting a question or two about tobacco use in a screening form or in an electronic medical record, and really not making it a big, large questionnaire. The next part of choosing a measure is making sure it's reliable, and that means that everybody who's collecting and reporting the data are doing it the same way, and so that two different people that would be using that measure or that way of collecting it would get the same answer for the same person. So sometimes it means you need to do a little bit of training with staff to make sure that they understand what it is you want them to document. So for example, if you wanted to ask about, okay, have you smoked recently? Well, what does recently mean? Have you smoked in the last week? Have you smoked in the last 30 days? So making sure that everybody is clear what the question is asking, that it's simple, and that, like I said, that people doing the same thing would be getting the same result for the same person. And if you aren't currently collecting anything, you can look to the literature. You can even ask us about whether we know of anything that are simple scales that already have or are based on established reliability. And one example that I want to show you, and we'll even come back to, is our tobacco use disorder treatment self-evaluation tool for behavioral health programs that we developed through New York City TCTTAC. It's available on our website, and I will walk you through how you can get to that later. But this tool is based on the Dual Diagnosis Capability Mental Health Treatment Index, which is a very widely used, reliable, valid instrument. It's been used not only throughout the United States, but in other countries as well. And what you'll see as you go through this document is there's a number of different domains. So there's questions and ways of measuring, how embedded policy is, whether you're tracking outcomes, the availability of educational materials or signs such as no smoking signs. And then there's an area that has several measures around screening and assessment, routine screening, whether it's documented, the severity of addiction, and so on, assessing stage of change for all of the mental health conditions and tobacco and other substance use. And then once you've done the screening and assessment, there's the domains that talk about treatment, what's documented in the treatment plan, whether the interventions are matched to the stage, group treatments, group curricula, medications to treat tobacco use disorder, and it gets into some of staffing issues, both around who's available and also training of staff. So there are 20 items on this. You could use this entire instrument if you're interested, and we'll talk about that a little bit later. Or if you knew, for example, that you wanted to improve screening in your program, you could use the screening item and just this and the anchors for that screening item to measure that in your program. So the final piece of choosing a measure is whether it's related. I think there's always a temptation to use data that you already have that might represent outcomes that are further away from your goal. So for example, you can imagine that people who reduce their tobacco use may have decreased ER visits or hospitalizations due to some of the health conditions that can be brought on by tobacco use. However, that's so far down the line than the changes you're likely to be trying to make right now that you may not really actually see any impact in hospitalizations for 6 months, a year, even longer after you're trying to implement a change. So it's very tempting to use data because it's doable, like we talked about before, but you'll want to really think carefully about what you expect to change first. So it could be as simple as consumers moving through stages of treatment. If you have a number of people you're working with who really aren't thinking about quitting tobacco, the first thing you're going to likely see are them moving from pre-engagement to engagement and then eventually to active treatment. If you have some folks who are starting to cut down on their cigarettes, you can track things like lower levels of expired carbon monoxide with a CO meter. You can document whether people have attempted to make a quit, even started trying to use NRTs to reduce the number of cigarettes that they're smoking, and those measures are much closer to the changes that you're trying to make than something like hospitalization. And please, if you have any questions, feel free to type it in the chat box, and we'll also have time at the end for questions. So then, once you've identified what you want to change and your goals and also the measure that you're going to use, you want to start thinking about, well, what changes can you make that will lead to the improvement? So this goes back to the work group we talked about earlier, and you can use this as a brainstorming session where everybody throws out all possible ideas, all possible changes they can make, include all perspectives if you can, all of the stakeholders, including consumers. You don't judge any of the possible suggestions. And as a group then, after everybody's kind of run out of ideas, you can go through and evaluate and decide which ones you think might actually impact or lead to an improvement, or what you might want to try first. So I've also seen people write about this as, how can you make it easier to do the right thing? So sometimes you know that you want to talk to everybody about their tobacco use, but it's so hard when somebody comes in with 10 different issues, and you might have 15 minutes or 30 minutes with them to remember that one thing. So making things easier can be embedding it in the process. So that could be adding a few questions to a screening form, or to the EHR, or to the visit form. And then finally, thinking about small incremental steps rather than giant leaps. So if you have nobody who has had a quit attempt, you don't want to think about going from 0 to 100%, and you don't want you want to think about the small ways to get there in process improvements. So if you're going to add something to the electronic health record, so what are the actual incremental steps to getting that done? Now, I don't know if people can see the raise your hand icon at the top right of your screen, but if you can, I would just be curious to see how many people have had experience with the Plan, Do, Study, Act approach to quality improvement. Okay, I see one X. So Megan found the no. So yeah, you can also do agree, disagree, or raise your hand. So the Plan, Do, Study, Act cycle is a very common approach to making changes in a system, and in a really very thoughtful or planful way. Everything we've been talking to up into this point really falls in that upper right-hand plan bucket. So figuring out what you want to change, the specifics, by when, the measure you're going to use, and some of the other changes, the brainstorming the changes that you can make. Once you're finished your brainstorming and evaluated and decided which of those you'd like to try, or you might want to try one or two, then you move into the do lower right-hand side of this circle, where you're actually implementing the change, you're collecting your measures, if it's once a month or every quarter or pre-post. This is where all your action is. You're putting your plan into action. Then the study part of this cycle is then taking a look at your data, and we'll talk about that in a little bit as well, but just to see, have we achieved our goals? Did we did we run into any challenges that we want to think through? And then finally, you act on that data that you've analyzed. And this takes a few different possibilities. So based on what you learn, you can either decide you've made no changes, or things didn't go at all as you planned, and so you can throw out that idea and try a whole new one. You can decide that it was so successful that there were no changes needed. You'll just continue, you'll embed it, it'll become part of your everyday practice, and you will adopt that change. Or more likely, you're going to adapt it. In other words, you've made some progress, or maybe even you've met your goals, but you realize that you can make it even better and try it again. And then you'll go back again, and you'll see that the arrows show that this is circular. Once you act on this, if you've revised it or adopted it, you can go back to, planning. Okay, what's the next change we want to make in a different area, or how are we going to measure this revised or adapted version of what we just went through? So coming up with what your benchmark is you'll want to get a sense of where you are right now. This is what's called your baseline. So you want to choose a reasonable goal, and we talked about that just a little bit earlier, where if you had 0 people who had a recent quit attempt, you don't want to say, okay, in 3 months we're going to have 100% of our consumers with a quit attempt. You want to have a more reasonable goal. Maybe 3 people within the next 3 months would be a reasonable goal. Whereas if you looked at your charts and you saw, oh, well, 90% of people who we know smoke tobacco have it documented in their chart, that's terrific. You might want to go from 90 to 98% or 90 to 100%. So looking at your baseline data really helps you choose what a reasonable goal is. And then you'll look at your data again at specified time point or time points. So it could be, for example, if you're doing a group, you want to look at group attendance every month and talk about it as a team to see, okay, is this going the way we expect? It took a little time to ramp up, but now we have a nice steady core group, or we had a few really good groups and then attendance dropped off. What might have happened? What changes could we make? Whereas other data might make more sense to look at less frequently, like once a quarter. Be sure you collect the data the same way at each time point so that you can compare. I think the easiest thing to think about, as people can typically relate to this, is if you're tracking your own weight through time and you're, say, doing 3 different time points, you wouldn't want to use 3 different scales to measure your weight. And also, you want to collect it the same way each time. So if your baseline weight was taken in the morning before you had breakfast with your shoes off, that's how you want to collect your 2 follow-up time points as well, just so that you know you're comparing apples to apples. When you're together as a work group, you can discuss whether you're seeing improvements and whether there's things that you might want to change to focus to help you achieve your goals. So again, like the group attendance example, sometimes you might need to reassess your goals and develop new targets, and that's okay. I mean, if your goal was having 100% of people who smoke offered medications to treat tobacco use, but it was 0% at the beginning, you might need to work towards that goal in smaller steps. And I think this final bullet point is really important and one that gets lost sometimes. We're busy, but when you achieve a goal, make sure you do pause and celebrate it with your team, with the consumers. It takes a lot of effort to make these changes, especially in busy work environments. And every goal and every step towards progress should be celebrated. So any questions on what we have gone through so far? You can hit *1 to unmute or put it in the chat box. Because the next area I wanted to step into was to talk a little bit about implementation plans. And maybe as I'm waiting for questions, again, if you use the raise your hand icon, you can indicate whether you could either raise your hand yes, or agree yes, or disagree if you have or haven't had any experience with implementation plans. Okay, good. Megan has. So Megan, please jump in. I'd love to hear your experience around this if you're willing to share. But again, implementation plans can come in, and I'll just go back to this cycle here, as part of this planning process, where it's essentially writing down everything that we discussed. It can help you, have a clear topic and focused area with specific objectives and time frames, who's responsible, what the benchmarks are for your performance indicators, which is essentially data or outcome measurements, which strategies to achieve the goals, using small feasible steps, and how you're going to monitor and update it. Here's an example of an implementation plan, and we actually have a template as part of the tools on our TCTAC website, which I'm going to show you again at the end of this presentation on how you can get to this. But you'll see here, there's this clear goal on the left-hand side, increasing the number of tobacco screening assessments completed and documented in the records. And you'll notice here that this is, again, very specific, to 90%, and by when, with a date. There's actually 3 strategies here that are listed to achieve that goal. So one is as part of intake, which falls on the intake coordinator, and then the initial diagnosis and continued monitoring, which fall on the primary clinician. And when you're evaluating the data during the study portion of that cycle, you can use this plan to provide an update, a status, and any revisions that you might want to do going forward. Pardon me a minute. So again, consumers really can benefit from seeing progress too. I don't know if anyone's had experience with this, in your own practice, but certainly, I am very motivated when I track my own health-related goals. So you can ask consumers to report the number of cigarettes they smoke a week and create a graph. You can use the carbon monoxide monitor. Both provides immediate feedback to someone, but also you can graph that through time if you're doing that regularly. And you can have people rate things like their energy level, how far they can walk, the number of steps they can take, and so on. That shows health improvements through time. And having that feedback to a consumer can be incredibly motivating. So I hope that this leaves you with a sense that data can inform your practice. We do have training and tools, and honestly, the best way to get started is just give it a try, and if it doesn't work out, it's an opportunity to learn and try again. I'm going to show you now, if you've gone, and in the slides, which will be available for download, you'll be able to link from the last slide to this website. This is our TCTAC website. And if you click on resources, you'll see there's a number of reports and articles, tools, fact sheets. And if you scroll down on the tools, you'll see, you can download the Learning About Healthy Living manual, the decisional balance, the importance ruler, which were motivational interviewing tools, also the self-evaluation tool that I showed you, an implementation plan, and much, much more. So I will leave this for questions, and also, Rusty, Noah, if you have any comments or follow-up suggestions based on what I presented. Just to remind folks, you can hit *1 to unmute. Rusty or Noah, do you have anything you would like to share?
Well, I just have a question to pose to the group. What things do you know? What data do you know is already being collected at your program? What types of data is being collected? And the data, Nancy, is data equivalent to outcomes, or is that data is the way you measure the outcomes?
I think it can be used interchangeably, but yeah, data is usually a way to characterize outcomes.
So I'd be curious to hear from, because I know that you probably, in the programs you worked, are probably already collecting something. Like what types of things are being collected at your program? You could use the chat box, or you could, are the phones unmuted or muted? Yeah.
They are muted, but I actually don't see anybody in on a phone, so I'm wondering if people are on their computers.
Okay. So you have to use the chat box then. Anybody? Okay, Megan. Remember, we're going to use this, whatever happens here, as like an outcome measure for the...
And while Megan's typing, I did want to just revisit this, where is it here? This self-evaluation tool. We are talking with agency and program leadership about the different kinds of technical support that we can offer to those of you who've gone through the training, so that you can, we can help you apply what you've learned, and we are offering this as one possibility. And if the agency or program decides they'd like to do a self-evaluation on the whole tool, we will actually create for you guys for free a really detailed report of kind of where you're at and some steps you can take in each of these different areas that can then inform an implementation plan. And you may not, and we wouldn't expect you to make all the changes at once, but you could, as a work group, look through and say, okay, let's tackle this one or these two first. We can follow some of these recommendations to get to the next level. So that's something that we're definitely talking with your agency leadership and programs about, that we hope can be helpful to you. Great. Rusty, do you want to field, since you asked the question about what...
Do you want me to read it, Nance? Okay.
Yeah, thank you.
So Megan B., Megan, you said, we collect data around if people want help quitting. Okay, so I guess the data is how many attempts have they made and what tobacco products they use. Now, Megan, do you mean how many attempts they made in the past or while they were, yes, okay. So this is, you're collecting, this is like baseline stuff, right? I guess. Nancy, you might be, yeah, so, so you ask them, do you want to help quitting? So you get this kind of a yes or no data point. And then there's a number that you have to collect, how many quit attempts that they made. And then there's, what are they using now? All right, that's kind of, that's pretty, I don't know, what do you think about those? I mean, they're very basic.
But
yes, but go ahead,
it's doable. I was going to say that fits right into the doable, simple measure. This is exactly the kinds of things that are likely to be successful because they are so doable. And as people are, attempting to quit, if you have a regular time frame for asking people, what tobacco products they're continuing to use, and whether they've made a quit attempt in the last, 30 or 60 or 90 days. That's perfect. You have baseline and follow-up measures.
Yeah. And just a question on the follow-up measure, Megan, is it, do you ask like in 3 months where a person's at in terms of wanting to quit, and have they made any quit attempts in the last 3 months? Is that how do you collect the follow-up information? Well, Megan's typing. I had the experience that, on their next visit. Wow. Okay. And so that is, and because there's what you want to collect, but then you have to collect it on something, right? You have to, how do you do that? You put it in the computer? Do you do a hard copy? Computer. Wow. You guys, that's pretty good. We have a checkoff box. Wow. And so then, I guess, are you a computer whiz, Megan, or does somebody else in your program? I would need somebody else. I would need Nancy to help me with this. We have an IT person could keep track. Well, that's kind of cool. You guys, that's pretty good. You know, I have the experience that Nancy was talking about where I worked at a program and we came up with this spreadsheet of all the questions we wanted to ask and all the outcomes, and we gave it to staff, and it went nowhere because nobody turned the data back in. So being doable is the first important step, I guess.
Yeah, and you know, having it be part of the computer as a check-off box, it makes it inherently more doable, and it kind of fits with that line of making it easier to do the right thing.
Yeah.
That's a great example of those principles.
Yeah. Megan, oh, you're the program director. Oh. Wow. What program, Megan, are you at? Cassie. You know Cassie, what is it?
It's on Staten Island.
Okay. A community health action of Staten. Okay, community health action of Staten Island. Well, cool. Hey, it's great that we have a program director on. I mean, because you could kind of get people to do this and organize it. And you know, one of the things about collecting this is it informs it's the quality improvement. So you could use it and say, well, this is really working. And Nancy, maybe you were saying this around PDSA. This is really working, or we're not doing so well. No one's made a quit attempt in 8 years. I'm being, I guess, facetious, but you know what I'm saying? And so you could take that, you could give that back to your staff, and they could say, well, what ideas we have to make it even better, and then they could come up with things they're going to do, and then you could keep tracking. So, yeah, that's great.
And I'm curious, because Megan, I know you had indicated you had some experience with an implementation plan. I don't know if that was around tobacco or something else. I was just, you know, curious what your experience was around that, and was it helpful?
Sure.
And if anyone else has had experience with implementation plans, that would be great to hear as well. Or even using data with consumers to track outcomes and how consumers feel about it. Okay. So you'll have to let us know how that experience is once you've had a chance to really get it off the ground. I don't know if anyone has any other questions, or Rusty or Noah or Annie, if you have any other comments.
I don't want to be rude, but I'd like to maybe call in some people to see what's going on with their outcome. So, Annie, is it Annie? Is that how you pronounce your name? You could just write in the chat box if you. Hopefully, you're still with us. Annie Almonte. Claire? Well, I'm at the point of giving up. Claire, just what program you work, you don't have to write a lot, but just like any kind of, oh, look at, here's a poll. There we go. Just Nancy sticking by that motto of making it easier to do it.
And I would just say, this is Noah at FIT, that while folks are completing this, responding to this question, when I think about data, I think I tend to feel overwhelmed pretty quickly because I relate it to statistics and numbers and all these things that I really don't understand well. But that's really not what came across in this presentation, Nancy, that, I think that piece that's, you want to do things that are doable and relatable and that, your whole staff can really implement with the people that they serve makes so much sense and makes data something that actually people can use and benefit from. So, I think it's a really kind of good approach to actually using in programs.
So thanks.
Yeah,
Go ahead.
I agree. I just want to second what Noah said, because the nice thing about the presentation that Nancy did is it's a way to involve all the staff in data, okay? And it kind of demythicizes, I don't even know if that's a word, but it takes away that anxiety around data, and it also gives information back to the staff in ways that they could use it in terms of improving the outcomes of the program. And then they could have input about what maybe they would like to see collected. So I think that's the big thing. And when the outcomes are there and they're going well, the idea of celebrating is a big piece, because it gets people motivated to do something that's becoming more and more important, which is to be able to say, this is what we collected as a baseline, and this is how things got better in lots of different realms, and funders want to know that, MCOs, all kinds of people want to. That's this value-based work that's going to happen. This is a way to be part of that.
That's right. And I think I like Megan's last word, since we are at 4 o'clock. I really appreciate the folks who joined us and participated, and for bearing with my coming and going voice today. But Megan makes a great point that it improves staff buy-in as well, because I think, it's very easy when you are, working in a situation and there's a lot of crises or a lot of high needs happening every day, to focus on those. And when you get to see data where it shows that what you're doing is actually making a difference and improving people's lives, it's tremendously motivating and satisfying, and can increase staff buy-in that it's actually worth doing these things. So the slides are there for you to download. You can click on it and choose download files. You please do visit our website for more tools and fact sheets and things you can use. Be on the lookout for future opportunities for technical assistance and